Welcome everyone. My name is 𝐒𝐔𝐁𝐄, and I am a professor assistant professor in the School of Rehabilitation Medicine at McMaster University. And I am a physiotherapist and an epidemiologist by background, and I do research on osteoarthritis. And today I have the pleasure of speaking with Dr. Gillian 𝐒𝐂𝐑𝐈𝐁𝐄. Dr. 𝐒𝐂𝐑𝐿𝐂𝐑𝐿 is the Sir John and Lady Eaton Professor and Chair of the Department of Medicine at the University of Toronto. And she's also a senior scientist at Women's College Research Institute. She is a health services researcher whose research has focused on addressing disparities in access for and outcomes of care for people living with osteoarthritis, as well as advancing our understanding of the patient experience. She has published well over 300 peer-reviewed articles and was the recipient in 2020 of the Clinical Research Award by the Osteoarthritis Research Society International. So welcome, Dr. 𝐒𝐂𝐑𝐿𝐂𝐑𝐿.
Thank you, Lisa. It's great to be here.
So I do want to let the audience know that unfortunately you weren't able to join us live today, so we are taping this session, but thank you for making the time. I know you have a very busy schedule, but let's jump right into it. So we both know that osteoarthritis is one of the most common musculoskeletal conditions, really second only to low back pain in terms of its global impact on people, like the number of people it affects, as well as the disability that it can create. But getting a diagnosis of osteoarthritis doesn't necessarily mean that you're going to have a joint replacement or that your joint has worn down. And we'll talk about these things a little bit more as we go on. And importantly, research over the past several years has made many important contributions to our understanding of the disease process. And so this has really helped with our knowledge pertaining to diagnosis and prognosis. And your research in particular has focused on hip and knee osteoarthritis. So now your bio that I have here, it really focused on your research contributions, but you have quite a clinical background. And I know you were the head of rheumatology at Women's College. And can you just share a little bit about that clinical experience and your experience in helping people with hip and knee osteoarthritis manage the disease?
Sure. That's a good place to start. I am a rheumatologist by training, and most rheumatologists focus on autoimmune diseases and particularly see a lot of patients with autoimmune inflammatory arthritis. So rheumatoid arthritis, psoriatic arthritis, lupus, etc. Mm-hmm. And when I was training in rheumatology, I kind of looked around and saw that there was really nobody paying attention to the aging population and the growing burden of really disease due to osteoarthritis. And so much against my mentor's recommendations, I decided to focus my career on osteoarthritis, which meant I hung out with the orthopedic surgeons more than I hung out with the rheumatologists. Right. But what I saw clinically over and over and over again was that my colleagues didn't want to see patients with osteoarthritis. They saw it as something for which they couldn't offer anything. They didn't see it as serious, which we obviously know it is. And I'm going back 25 years. So, but I would like to say things have changed, but I'm not sure they have. So I saw a lot of people who had very advanced osteoarthritis and nobody really had offered them anything. They'd been told that it was just aches and pains of aging, that there's nothing that could be done, and there was sort of a fatalist waiting for their joint replacement approach. And I also saw that there were a lot of, because pain was the number one reason they were coming to see physicians, whether it was their family doctor or a specialist, and disproportionately women who are affected by advanced osteoarthritis. There was also a bit of a gender bias. around, well, women are just sort of the weaker sex and couldn't handle it, and a lot of discounting of the suffering of our patients due to osteoarthritis. And I saw that in particular with respect to whether or not they were recommended for joint replacement or even considered for joint replacement. So it was really a clinical experience that showed me that people didn't pay attention to OA, that patients were consistently being turned away as you're just getting old and it's nothing important. And that made me really frustrated and really spurred on my research career.
Yeah. That's wonderful. And you've touched on a number of kind of some highlights there of some of the work you've done. And we might come back to that, some of the particularly the gender bias that you mentioned. But before we go there, so you talked about rheumatology having a focus on inflammatory types of arthritis. And in our audience today, we'll probably have a mix of people who perhaps have not yet been diagnosed with osteoarthritis. They might suspect they have it. Others who have who have potentially just been diagnosed, and others who might have been living with the disease for a while. So I wonder if you can just talk a little bit more about the different types of arthritis so that we have an understanding. How is inflammatory arthritis different than osteoarthritis?
So great question. And in fact, our understanding of osteoarthritis continues to evolve. I would say that is something that has grossly changed for the better in terms of understanding. So when we talk about inflammatory arthritis, most people are talking about, or at least clinicians are talking about, autoimmune diseases. I mentioned rheumatoid arthritis as the most common of those. So it's where there's a genetic predisposition or turn on of the immune system. So it starts attacking normal tissues in the body. And in people with inflammatory autoimmune conditions like rheumatoid arthritis, these T cells get turned on over the whole body and start to attack particularly the synovial lining in the joints, and it starts to chew away at the contents of the joint. In contrast, osteoarthritis is totally an inflammatory arthritis, but the inflammation is not due to auto-inflammatory impact. In fact, what's happening is there are two main stressors on joints, particularly load-bearing joints. The stressors from bearing a load, so weight bearing, or using your thumb over and over for lifting, etc., and then systemic influences. And we can go into that later if you wish, but basically those two factors or pathways cause a series of stimulating impacts on the tissues of the joint, which are inflammatory. It causes inflammation in the joint tissues, all of the joint tissues, which ultimately results in breakdown of those tissues and what we see as osteoarthritis. So there is inflammation. It's not at the same level as what we see with autoinflammatory conditions, but it is definitely a disease characterized by inflammation, catabolism, or major increased turnover of the joint tissues, and finally failure to support the function of the joint.
Yeah, that's a really great answer. And I think it's important what you said about how it's a disease of the whole joint, and it touches on almost all of the different tissues in the joint. And so it is different in that it's not autoimmune based. It doesn't kind of, affect the tissues in the same way. But importantly, people, I guess, should understand that inflammation does play a critical role in OA. So now that we know, kind of have a better understanding about the differences there between, say, inflammatory arthritis and OA, what would you say is the best way to explain to someone, say you have a new patient in front of you who you're just diagnosing with osteoarthritis? How would you explain the disease to them And what are the most important points that you think people should understand?
Well, it is still complicated. So I would say it's a complex condition. And I would say that unlike many other diseases, there are many factors that can cause osteoarthritis. So it's not one size fits all. Every patient is a little bit different. But the two main pathways, as I already mentioned, are things that perturb the way the joint functions. So putting too much stress on it or changing the alignment of it so that the stresses are abnormal as the joint moves, those kinds of things. And then the second things are these whole body influences, like the impact of obesity with systemic or full body inflammation related to release of inflammatory factors from the fat tissue, which we know is highly prevalent in people with osteoarthritis. So there's sort of these two separate pathways acting, and they're acting in different people in different ways. And the joint tries to respond to these stresses as well as it can, which is quite different from inflammatory arthritis. So we grow new bone to try to stabilize the joint. But eventually, unless we really modify what those stresses are, which we can, but the joint will fail. So it's a sort of a stresses on abnormal tissues or on normal tissues even over long periods of time.
So you've mentioned now a couple of times the term failure, joint failure, and I want to kind of talk about that a little bit more because you were just at the ORSI conference, which is the International Conference on Osteoarthritis, and unfortunately I wasn't able to make it this year, but I did see on Twitter somebody posted a slide with a very important message that said that OA is not a degenerative disease, and that term should never be used. And I would extend that even further to say, you know, we shouldn't be using things like bone on bone and wear and tear. So can you tell us a little bit more about what's actually occurring in the joint? You talked about repair, about growing bone. If it isn't degeneration, what's important for people to understand that what's happening there?
There's active inflammation going on. So if you picture a bunch of cells that come into the joint in response to these stresses, they're macrophages particularly, and they start producing all sorts of inflammatory mediators, which bring other cells into the joint. And they wreak havoc on the normal maintenance of the joint tissues, on the cartilage, on the bone underlying the cartilage, in the synovial tissue, on the ligaments, the tendons, everything. So it's active inflammation which produces catabolism, which is breakdown. So there is breakdown, but the breakdown is a result of inflammation. It's not the result of wear and tear. And the term degeneration or wear and tear leaves people with it's just normal age-related use of a joint. Whereas in fact, only about 40% of people in their whole lifetime will ever get osteoarthritis, a little bit higher in women. But like most people won't get osteoarthritis. So it's this inevitable wear and tear dogma that has left people without active treatment and with a sense that you just grin and bear it. So it is inflammation. It is active inflammation, and all the treatments that are being developed right now are looking at blocking these various pathways of inflammation and catabolism, breakdown in the joint tissues.
Right. And important for people to understand, because you mentioned the repair piece, that when you're talking about failure, it's really about this kind of imbalance, right, that happens between that catabolism that you talked about and the joint's inability to repair itself, and that's kind of where the failure comes in.
Right.
So we have later in the day today, we're having a session on myths that are common with people living with osteoarthritis. What are some of the most common misconceptions that you've heard from patients over the years?
It's funny, one of our graduate students, Lauren King, and I just published a chapter in a textbook on myths and pearls of osteoarthritis. I would say we've already touched on some of them, that it's an inevitable part of aging that is due to wear and tear. So I would say those are probably the two biggest. That it isn't a major or serious disease, that it's just, you know, something that you grin and bear. But we've now really clearly shown that as the joints aren't able to allow you to move about your normal way, and in particular cause difficulty with walking, that people become physically inactive, and that does increase risk for cardiovascular disease, heart disease, hypertension, high blood pressure, diabetes, complications of diabetes. So we now know that osteoarthritis is associated with higher mortality, so increased risk of death, and that we think that is probably mainly related to inability to function. And if you think about it, it also prevents people from working. It's associated with early removal or retirement from work, loss of ability to live independently. And like the last place I think most people want to age is in long-term care. So I think that this is an unimportant disease. Then there's a whole bunch of myths around how we manage osteoarthritis. And I would say that first and foremost, well, they're all kind of at the same level, that people are afraid to use a joint that's affected by osteoarthritis. They're afraid that if they use it, it will make the disease worse. And that is not true. You can actively use a joint, and actually that will improve your pain and your function in that joint. You don't want to abuse it, but use it or lose it is really true for osteoarthritis. You need to move. So protecting an osteoarthritic joint is not the right approach. Secondly, a lot of people believe that once you're really far gone, so you've got a constant pain and disability, and you're going for joint replacement, that there's nothing useful and physical activity won't be useful. But there are lots of studies that show that being more physically active with your osteoarthritic joints actually can still improve pain and function and mood and sleep and fatigue, even in people with advanced disease. So it's never too late to use physical activity. And I guess the third thing, all related to physical activity, is that there are no effective treatments, but in fact, physical activity is a highly effective treatment, and more effective even than anti-inflammatory medications. So when people say there's nothing I can take because I have other problems, or what, that's just not true. Physical activity, weight loss, which nobody is it's difficult to think about weight loss, but physical activity is something that everybody can do. And topical use, so on the skin use of anti-inflammatories, which is also pretty darn safe for everybody, but it's mostly around the role of physical activity, that lots that can be done about it.
So that's really great, and obviously a great message for people to hear, the importance of physical activity and that it's helpful in maintaining joint health. Now, earlier you did touch upon how one of the pathways leading towards joint failure is load and excessive loads on the joint. And now on the other hand here, you've been talking about the importance of physical activity and continuing to use it. So can you talk a little bit more about kind of the discrepancy in those two things? So, what kind of use is acceptable, or what kind of loads are not acceptable? How do people, understand how to navigate that? It sounds pretty tricky.
It is tricky. Well, theoretically, it's tricky, and exactly that sort of seems like an oxymoron. It hurts when I weight bear, but you're telling me to go and use my joint.
Yeah.
So first off, and I'm speaking to people that know much better than I do, but this is the role of physical therapy, as far as I'm concerned, that we need physical therapists to help our patients figure out what's working for them and what isn't. Physical activity is important to strengthening the muscles around joints, and those strong muscles help protect the joints when you're using them. So part of it is around building the strength and balance, so that when you're using your joints, you're using them safely. So that's what physical activity will do versus somebody that tries to do something on a completely under supported weak joint. Second, we should be exercising, addressing changes in, for instance, the mechanics. So let's say somebody's very knock-kneed or bow-legged. We might need to address that with a brace or with an insole in their shoe, or sometimes even surgically, but we basically need to address the mechanics of the joint, how the joint is functioning in use, to reduce the added forces through the joint when people are being physically active. So those are sort of the two main things. The reality is that when you use a joint, it brings positive mediators into the joint. It helps with circulation. Circulation brings in those good, positive, reparative, restorative substances into the joint. And so it is a balance of pros and cons, but the pros outweigh the cons, largely because it builds your physical fitness, your strength. We can address the mechanics if the joint or the leg is misshapen, and overall you do better.
Great. Now, I'm just going to switch gears a little bit and talk a little bit more about pain and some work that you did a few years ago that has really helped our understanding of the pain experience in people with, particularly with hip and knee osteoarthritis. So you ran a number of large focus groups internationally, so talked to people all over the world, and what you basically talked to them about their experience of living with pain with hip and knee OA, and they said that pain was intermittent. It could also be constant, or it could be a mix of the two. I wonder if you can tell us a little bit more about the findings from these focus groups and the understanding that we've gained.
Yeah, thank you. This was work done collaboratively with a lot of different people under Orthe and another research group, AMERACT. But what we were trying to get at is, how could we do a better job of measuring the pain experience of people with osteoarthritis? Pain is the number one reason that people seek care. Pain causes functional limitations, inability to do the things that you want to do. So we wanted a better way to measure it. And we actually use an approach that the cancer field uses to ask about the most distressing features about their pain and how those distressing features changed over the trajectory of their disease. So I think it was the first time we actually asked people to tell us about how did it start and how did it change over time. And what I think was really cool is that it didn't matter who we talked to, as you said, where in the world, although all English speaking, they all said the same thing. They said that at the beginning, they really just were bothered by discomfort in their joint when they used it to do something fairly high impact. So a sport or, traveling and hiking at a time when, they don't usually do that. So it wouldn't really curtail most of their day-to-day activities, but they would notice it. And that was the intermittent pain that usually came on after a trigger, and the trigger usually being use of the joint for, sport-related or vigorous activity. And then they said that importantly, not everybody progresses. people progress over time very differently, but people who did have worsening of their pain experience would go on to experience that intermittent pain more frequently, and it would become much more bothersome. So instead of coming on only when they were doing something fairly vigorous, a sport, for instance, now they were finding that walking upstairs or just walking would start to trigger their pain. And a lot of them didn't describe pain. They would describe aching, stiffness. In fact, we would have arguments over, no, it's not pain. They used all sorts of different descriptors, but it was discomfort. It was not a good feeling in the joint. And as time progressed, that pain changed over time also. And sometimes it went from being just a discomfort that lasted for moments to something that could really burn or radiate down their leg, or really it changed in its characteristics. And many of them then developed a more constant background aching pain that was sort of with them all the time, got worse as the day progressed, was often the thing that kept them up at night, but it was on the background of this intermittent activity-related pain. And at the end of the course of their disease, in order to avoid that activity-related intermittent pain, they'd really stopped doing an awful lot of things. They'd given up a lot of activities. They'd moved to an apartment rather than someplace with stairs, quit their jobs, whatever it was. But because it had moved so slowly, they didn't really realize how much they'd given up until you really pressed them, and then they could see what they'd given up. So at the final stage, they talked about pain that came on without warning. So it wasn't triggered by use of the joint. It just suddenly would get a horrible pain. Sometimes it was associated with the knee giving out, for instance. So suddenly the knee would just collapse on them. But others said it was just a pain that just came out of nowhere and was really sharp and really uncomfortable. So we learned a lot about the nature of the pain and how it changed over time. And, you know, I've done a lot of research over a lot of years, but this was the first time that when we presented the findings back to people living with osteoarthritis, that there was a look on their faces like, you've got it. You actually, that's it. That's the experience of pain in osteoarthritis, which is a really gratifying feeling that, you know, then we have to figure out, okay, why does it evolve like this? What are the mechanisms and the etiology of those different pains, which you and others have worked on a lot.
Yeah, and a really great result of this research was that you created a new outcome measure that we can all use in our studies. It's called the 𝐒𝐂𝐂𝐑𝐈𝐁𝐄, and it measures intermittent and constant pain. And it's really wonderful because we're not just saying, oh, tell me your pain intensity out of 0 to 10. And, you know, we're now actually getting information about the quality of the pain. And we're able to relate that, as you said, to their stage of the disease. And as you said, myself and others are starting to use this to really inform our understanding of the pain, underlying pain mechanisms. So thank you for that contribution. It was really important. And I think many more good things are going to come from that.
Yeah.
So I wonder, just staying with this and knowing again that we have lots of people with lived experience that are going to be watching this, if you had a patient in front of you and knowing what you now know about these different types of pain and how they occur in the disease process, and say this is somebody who's you're newly diagnosing with either hip or knee OA, what would you tell them about perhaps what to expect about the pain experience? That you know, as you said, you know, we may not have someone progress to having a joint replacement, but you know, many different things can happen along the way. So how would you put that in perspective for someone?
So I think what I would it partly depends on at what stage of the disease they came and saw me. So if they were more advanced in their disease versus very early, I would probably have a bit of a different response, because clearly if they're more advanced, they've already progressed. Right. But as I said earlier, not everybody progresses. And a lot of people will have fairly stable intermittent pain. They'll get flares. So we haven't really talked about flares, but often people with osteoarthritis will use their joint a little too much, and they'll get or something happens, whether it's a change in the weather or, you ask your patients, that's what it'll be, but they'll suddenly have a few days where the joints are really sore, and then it'll settle down. And again, that's probably inflammatory, that's inflammation. What causes it? We're not really sure. We're trying to measure it better. But I would tell them that that with physical activity in particular, they can keep their disease very much under control. It may actually their symptoms may go away. I've seen people with really advanced severe pain become physically active and completely resolve their symptoms. I've seen people come off waiting lists for joint replacement from physical activity. So I think and some weight loss where relevant. So I think managing your disease can make a huge difference. Not everybody by any stretch of the imagination goes on to joint replacement. And a lot of people just have either steady intermittent pain, and probably no more than 10 or 15% will progress rapidly. So I would say for most people, it's totally manageable pain. I think the other thing that we didn't really talk about is the impact of all these other things that are going on in somebody's lives on the pain experience. Yeah. People with osteoarthritis often don't sleep well because they roll over, or they've got that pain discomfort that I mentioned that keeps them up at night, or they have restless leg syndrome or some other sleep disorder, and sleep just makes their pain experience worse. So sometimes we have to really just look at, are you sleeping? And then fatigue as well, which can be a result of lack of being physically active, which sounds crazy, but you get more energy when you exercise. So looking at fatigue, sleep, and mood. So depression, anxiety also make the pain experience worse. And I think, again, back to clinical experience, often people will be in chronic pain, and so their health provider will say, well, of course you're depressed, you're in pain. Well, no, that you can treat the depression and relieve the pain, and it's all coupled. So you don't ignore mental health or mood disorders in the setting of chronic pain, you treat them. So again, it's assessing the whole person, what's going on in their lives, what can we improve? And it may not be targeting the pain specifically, it may be targeting something else, but I think that we can generally approach this successfully. Yeah,
that's a really great message. Again, coming back to physical activity and its importance. And I think, when people do have pain and they are fatigued, obviously there's not a lot of motivation there for them to try and approach physical activity. But if people can just start somewhere, right, and find just a small goal to achieve, be it walking a little bit further, or maybe it's starting, one new exercise or something, a new activity, right? Something to make that change, and then give it time to see that positive impact, right? As you mentioned, that the disease lasts over many, many years. And so it's important that we kind of persist in our good behaviors to try and manage the disease.
Yeah, then one of the nice things about physical activity is that the biggest improvement your health will have is going from really sedentary to some physical activity. So you don't have to suddenly become an athlete.
Right.
I am a total proponent of walking, because everybody has access to walking in some way, shape, or form. I guess some climates are averse to walking. I've got bad OA in my big toes, And I will never wear a pretty pair of high heels. Actually, I don't think I really ever liked high heels, but so there are great runners out there now. And, there's lots of ways that you can be out of doors, which also improves your mood and your sleep. It doesn't have to be a gym membership and workout clothes and all of that. It can just be a walk.
Yeah, really great message for people to just try and do what they can wherever they can, right? Just make a start. Yeah.
Exactly.
Okay, so we're just going to switch gears slightly again. So I know we've talked about pain. We've talked about some of those what we call structural changes that occur in the joint when we were talking about failure and repair, etc. What do you think is important for people to understand about the relationship between pain and what we see on somebody's X-ray?
Yeah, I missed that point in the myth. So
Right.
one of the myths that's out there, which a lot of physicians believe, is that we make a diagnosis of osteoarthritis by looking at an X-ray. We do not make a diagnosis based on X-rays. In fact, X-rays aren't even very useful for us. Why is that? Well, an X-ray tells us, gives us information only when you've actually lost space between the bones of the joint, because it's only really showing you the bones. So you don't see what's happening in all the other joint tissues until you're really late in the course of disease. So X-rays in people with bona fide osteoarthritis can be completely normal early on. And furthermore, we don't treat an X-ray if somebody doesn't have symptoms. Right. So if we had an abnormal X-ray and the person felt perfectly fine and was able to do what they wanted to do, we wouldn't do anything. But probably more importantly, we see lots of people who have pretty normal X-rays and are told, no, you don't have arthritis, but there's a lot of discomfort. Nobody offers them any treatment. So long and the short of it is that the two don't line up well. They are not synonymous. We don't always see X-ray changes with symptoms, and we don't always see symptoms with X-ray changes. You could MRI a joint at great expense, and in Canada at a great weight, probably.
Yeah.
In fact, I had an MRI booked, and I completely missed the date because it was a year later, and I just forgot about it. It was so long waiting. But anyhow, you'll have more information, but really, you don't need it. You just need to talk to the patient and examine the joints. And if the joints are painful when you push on them, and the range of motion might be reduced, and it hurts when you stress them, there might be some warmth or swelling, and the person has symptoms, aching, discomfort, locking, crunching of the joint, you know that they've got osteoarthritis. You don't need an X-ray.
Right. Yeah. And I think this goes back, kind of speaks nicely to our previous question about wear and tear and degeneration and bone on bone, and is that we could see somebody, right, with who's, like you said, whose X-ray really doesn't look good, but they're not really complaining, which is really interesting, right? And then we see the opposite. So it's really about, like you said, we don't treat an X-ray, we treat the person, and we need to address all those things that you were mentioning, like fatigue and sleep and their pain and their mood, and really try and address that whole person and what's going on in their life.
Absolutely.
Yeah. All right. So I want to just start to wrap up a little bit, but I wonder if there's just any particular piece of advice or knowledge that you want to share with people who have osteoarthritis that maybe we haven't touched on just yet.
Well, you've done a great job of asking all the questions. I think the biggest thing I would say is that I wish it weren't the case, but many physicians are not comfortable diagnosing and treating osteoarthritis. And we're working on it.
Mhm.
But one of the reasons they're not is because they're not comfortable with what they do once they've diagnosed it. And, you know, it would be crazy to say that nothing will happen until there's a pill that you can take that cures osteoarthritis. But it takes a lot of time to talk to a patient about physical activity and weight loss, and yet that's what they need.
Yeah.
So I guess what I would say here in Canada is that if you've had persistent activity-related joint pain or joint discomfort, and you're not getting a diagnosis, first off, you can be seen, depending on the province you're in, by a physical therapist and have an assessment. In many provinces, a physical therapist cannot make a diagnosis, but they can make a suggestion.
That's
and
right.
they can actually suggest that you see somebody who actually knows how to make a diagnosis.
Mhm.
Similarly, I think, you know, often patients have come to me from chiropractic professionals and sports medicine
Mhm.
because they can make a diagnosis and refer you. Again, depending on the province, we have the Arthritis Society and the Arthritis Rehabilitation and Education Program, which is in a remodeling phase to really increase its focus on osteoarthritis because there's so much of it and it's such a burden on the population. But you can go to the Arthritis Society in several provinces without a referral. So I guess, you know, that there are resources out there. I would call the Arthritis Society if you're in need and let them help you navigate the system.
Yeah, they're a tremendous resource, and they have just a tremendous network of therapists treating people with all forms of arthritis, but obviously osteoarthritis. And so, yeah, just a tremendous resource to access clinicians as well as access multiple educational resources on their websites. They have all kinds of videos and information sheets that will help people understand you know, what it's like living with osteoarthritis. And as we know, education is very powerful in understanding what you're going through, right? We haven't really talked about that so much, but yeah, really important to be educated about this disease. So if I can just follow that up with, you know, talking about the diagnosis, what would your advice to a patient be if this, let's say they were going to see their family doctor or the physiotherapist or whatever healthcare professional, and they suspected or thought they had osteoarthritis? What do you think it's important for them to ask their clinicians?
Well, actually, we created a patient-oriented toolkit with the College of Family Physicians and the Arthritis Alliance of Canada a few years ago, which is available online, that actually walks them through what they should talk to their family doc about, what's happening, and advocate. It really empowers them. So you know, you're making me think, whoa, we should. So that is available. I'm pretty sure on the Arthritis Society's website, there's a link to it.
Okay.
So toolkit, OA toolkit.
Yeah.
They have to push. They just have to push that this is important to them. And part of the problem is that people are going for other reasons, and it's difficult in a short period of time to say, well, yes, you're taking my blood pressure, but I've also got a sore knee. So it's empowering people to ask for hands-on assessment. And if the physician doesn't feel that they have the time or resource, then ask them for a referral to a physical therapist. And again, then we've got a money barrier in many parts of Canada where physios are not covered. So that's where, again, the Arthritis Society may be helpful to find them access to somebody without cost.
Right. Yeah, great advice. And particularly what you're saying about, previously you've talked about there being kind of a, not optimal management of osteoarthritis in the past, that it's really important that the patients advocate for themselves and make that push and ask those questions, ask for those referrals, so that they do get the care that they need.
Absolutely. And understand that those myths that we talked about are alive and well, and they're alive and well in their physicians' minds as well as in their minds. So there's a lot of hurdles to overcome, but I think if they were to see a physical therapist, I keep harping on physical therapists, but they will have the skills to really look at their joints and give them a suggestion or two, and also to recommend some physical activity, which could be all they need.
Yeah, and interestingly, we know like people always want to get an X-ray, right? They want to see what that X-ray says, and as you said earlier, and as you're saying now, see a physical therapist. You don't need an X-ray, right? That's not needed to confirm your diagnosis. And often you might be able to see a physical therapist quicker and sooner and actually be able to spend more time with them than you would be able to your family doctor, right? So that could be an easier pathway for people. And in most provinces, you don't need a referral. You can just book directly. So there's my plug for my profession.
You're making me realize too that people should also talk to their pharmacists. The local pharmacist has a lot of information about managing their pain and what's safe and what's not safe. So I mentioned topical, so rub-on anti-inflammatories. They should be the first line go-to. If you don't have 20 joints involved, if there's a couple that are really bothering you, and those are available over the counter as well.
Yeah, I know my mom used that on her knee and I found it very effective. So yeah, that's great advice, and really good advice to bring in that pharmaceutical aspect. Like it is really a whole team that you want helping manage you, right? Your doctor, a therapist, or some other type of allied health professional, as well as a pharmacy, because pain management is multifaceted, right? And like you said earlier, it's not one size fits all.
Exactly.
All right. Well, thank you so much, Gillian, for your time. This has been wonderful, and it's just been a wealth of information for patients and clinicians. And I'm sure that they have all learned something, and hopefully that it'll help them in their own self-management of this disease. We look forward in the future to seeing the research that we're all doing help improve management for people, and we are seeing some exciting changes there. So
thank you, Lisa. Thank you very much for inviting me to participate in this conversation.
All right. Thank you so much. Take care.
Bye-bye.